Okay. Surgery 8.
8, yeah, the last one. Okay, surgery 7 wasn't that bad. We had like 9 mistakes, so it's good. Let's try 8.
Okay. One day after undergoing One day after undergoing uncomplicated splenectomy for management of injuries sustained in a motor vehicle collision, a 43-year-old a 43-year-old man has sudden onset shortness of breath while receiving transfusion of packed red blood cell. He also has moderate pain at the IV site, moderate back pain. He has no other history of serious illness. His medications are hydromorphone, subcutaneous heparin. He is diaphoretic. Temperature is 37.2. Pulse 90 per minute. Respiration 24 per minute. Blood pressure 120 by 60. Pulse oximetry on room mirror shows an oxygen saturation 97%. Examination of the skin shows no abnormality. Breath sounds are clear bilaterally. No wheezes or rhonchi are heard. Abdominal examination shows a well healing surgical incision. Which of the following is the most likely mechanism of this patient's condition?
Ready?
Yes.
Let's perform antibodies to transfuse RBCs. At the most likely cause of this patient acute onset shortness of breath and back pain, which is concerning for acute hemolytic transfusion reaction. So life-threatening condition that occurs because of ABO incompatibility, which is often the result of clerical error. Patients with type A blood possesses perform antibodies against the B antigen and on the surface of erythrocytes, while patients with B possess antibodies against A antigen. Those with AB um, blood lack perform antibodies to both antigen as they possess them on their own erythrocyte. Patients with type O blood have antibodies against both A and B antigens. Given this, it is critical that patients receive the appropriate type of blood for the specific blood type. As an example, patients with type A blood can only receive type A or type 0, okay, blood from a donor, but not type A or AB, not type B or AB. ABO incompatibility leads to acute hemolytic transfusion reaction, AHTR, which results in profound hemolysis and often presents with flank pain, fever, hemoglobinuria, positive direct comes test, but most may rapidly progress to DIC, shock, and death. Treatment includes immediate cessation of transfusions followed by supportive care. The blood bank should be contacted immediately. It's not B, immune response to transfused plasma proteins. May refer to either anaphylactic reaction to donor immunoglobulins as might occur in patients with IgA deficiency or inflammatory cascade from the presence of inflammatory cytokine in the donor plasma that occurs in febrile non-hemolytic transfusion reaction. In either case, this patient is most likely suffering from acute hemolytic transfusion reaction. Okay.
Next. A 62 year a 62-year-old woman has shortness of breath immediately after beginning transfusion of fresh frozen plasma and 2 units of packed red cell to manage acute lower GI bleeding. She has been hospitalized for 24 hours. 5 years ago, 5 years ago, she underwent mechanical valve replacement for treatment of aortic stenosis. She has no other history of serious illness. Her only outpatient medications are warfarin, lisinopril, which has been discontinued since admission. Her temperature is 37.8 degrees Celsius, pulse is 110 per minute, regular respiration is 28 per minute, blood pressure is 100 by 60 millimeter of mercury, pulse oximetry on room air shows oxygen saturation 82%. Crackles are heard from the lung bases of the mid-lung fields. There is cyanosis of the upper and the lower extremity. A urinary catheter is draining. A urinary catheter is draining a clear urine. A chest X-ray is pending. Which of the following is the most likely diagnosis? Crackle. Ready? Is it
Mm,
Raleigh? It is acute hemolytic transfusion reaction to happen. For this to happen, urinary catheter show bloody urine, isn't it?
no, not. I mean, it's not required, but yeah, it may happen.
But
Yeah,
the evidence may show some sort of hemolysis in the form
yeah,
of anything.
yeah, yeah. Yeah. Well, the previous question was there was not really a type of hemolysis, right?
The first question.
Yeah, and it was acute hemolytic, whatever. But yeah,
But
I think you're right. It may be, it's probably Trally.
because there is crackles, and
Mm, uh, yeah, yeah.
are you thinking anything else? Like you were thinking PE or anything else?
No, no, but PE wouldn't show crackles. Um, yeah, yeah. I'm going with that. I'm going with that. Okay, let's see. Yeah, it's Trally. It's the most likely diagnosis in patients with sudden onset dyspnea, hypoxia, fever, following transfusion of red blood cells and plasma. So hypoxia, fever, dyspnea. Rally is characterized by respiratory distress, often with hypoxemia, cyanosis, fever, new infiltrates on chest cells that develop 6 hours after transfusion of blood products, erythrocyte, fresh cells, and plasma platelets. Frequently, symptoms develop within minutes to hours after starting the transfusion. The pathogenesis of Rally is thought to involve abnormal priming of neutrophils in the lung, which, when exposed to inflammatory cytokines present in transfused blood products, undergo widespread activation within the lung parenchyma. Release cytokines are ROS species, among other inflammatory components, from activating neutrophils, cause endothelial dysfunction, and rapidly lead to non-cardiogenic pulmonary edema. This contrasts with pulmonary edema that develops in patients who develop respiratory failure secondary to TACO. Treatment is with supportive care, which may include implementing non-invasive or invasive ventilation, vasopressor, antipyretics. Importantly, patients who recover from TACO can receive additional blood product, but this product should not be from the same prior blood donor. It's not acute hemolytic transfusion reaction. Results from transfusion ABO incompatibility. When this occurs, perform antibodies against donor antigens on surface of erythrocytes lead to profound hemolysis and variety of symptoms such as dyspnea, flam pain, dark urine, DIC, date. And it's not, what was I? No, pulmonary embolism. refers to blood clot that embolize from venous to one of the pulmonary arteries. The severity of presentation depends largely on the size and location of the thrombus, but tachycardia, hypoxia, and chest pain, diffuse cracker on pulmonary will be unusual. Additionally, the temporal, yeah. Next.
Yes, an 18-year-old man is brought to the emergency department 30 minutes after sustaining injuries to the head, chest, and abdomen when he was thrown out when he was thrown from the motorcycle. En route to the hospital, he received 2 liters of crystalloid. On arrival, his temperature is 35. On arrival, his temperature is 35, pulse is 110 per minute, blood pressure 115 by 90, GCS score is 11. Examination shows multiple ecchymosis and abrasion. His hematocrit is 29. 2 units of packed red blood cells are administered. A CT scan of the head shows diffuse external injuries, and X-ray of the chest shows pulmonary contusion with pneumothorax. CT scan of the abdomen is shown. Which of the following is the most appropriate next step in the management of his abdominal injuries?
Can you see something on the CT scan?
In the CT scan,
Uh, yeah, yeah.
there are some fluid
Um,
accumulation
where?
above the liver. I am feeling that may not be correct, but in the right side there is something.
In the right side.
Yes, on the
Okay.
left side there is fluid accumulation. I feel like that. Okay, I don't know actually.
Oh, ah, obviously, CT scan of the shoot, Jesus Christ. That was not. This is not a good question. Okay. So this is the liver, and this will be the spleen. I don't know if this is something that matter. I feel like it's something. So should we do?
Patient is hemodynamically not stable. Temperature is very low.
Oh, it's very low. But Glasgow coma scale is pretty. It's normal. And
Glaucoma scale is for ICU management, isn't it? It does not show the hemodynamic instability.
oh,
Like
I-
like if somebody's BP is 90/60, his GCS would be normal.
really?
Yes,
Oh, I didn't know. Okay.
GC,
Oh.
GCS comes with the head injury mostly.
Okay. Okay. Let's pick one. I don't see anything on this. Here, you need to see something on the CT scan. I don't see anything. So I. Okay.
Yes,
Okay.
there is
So,
something in wrong in the spleen.
yeah, I saw it. It was this thing, but I didn't know if we're supposed to do laparotomy. The spleen is commonly injured in blunt abdominal trauma. Injury patterns include, but are not limited to, devascularization, contusion, laceration, rupture. CT scan of the abdomen demonstrates free fluid around the liver and the spleen. Around the liver, and I guess that's, I don't know. Likely acute blood products given the trauma. The spleen visualized in the left upper quadrant is lacerated, indicated by bright extravasation of contrast in areas of organ parenchyma. I think it's this thing. Splenic laceration and rupture can lead to hemorrhage into the peritoneal and retroperitoneal spaces, which can result in hemodynamic instability characterized by tachycardia and is severe hypotension. Patients with spleen rupture may have left upper quadrant tenderness, peritonitis, with blood products irritating peritoneum or refer pain to the left shoulder. Second, yeah. Secondary to diaphragm irritation. In hemodynamically stable patient, minor spleen injuries may be treated non-operatively with Observation and reassessment. In unstable patients, laparotomy is required for repair or splenectomy, depending on the nature of severity of the injury. It's not C. It's not C. Ultrasound can be helpful adjunct imaging modality in the setting of stable blunt trauma patients. A fast examination can show intraperitoneal free fluid. However, this patient already has CT scan with more detail about specific injury and the presence of free fluid. So a fast examination will provide no additional thing. Diagnostic peritoneal lavage involves aspiration of peritoneal contents, infusing sterile saline into the peritoneal cavity, and analyzing the effluent. If blood, food particles, bile, amylase, sulfurs are found, exploratory atomotomy is indicated as the presence suggests hollow or solid viscous injury. This patient already has a CT scan demonstrating free fluid, so aparotomy is next. I wish we could see the free fluid. Okay, next.
Okay. A 20-year-old man is brought to the emergency department. A 20-year-old man is brought to the emergency department 50 minutes after being involved in a motor vehicle collision. He was restrained. He was an unrestrained passenger on arrival. He is alert. He says that he has neck pain and numbness in her legs. He cannot move her legs. His temperature is 37.2, pulse 70 per minute, respiration 20 per minute, respiration 20 per minute, and is unlabored. His blood pressure is 80 by 50. Examination shows a patent airway. There is no jugular venous distension. There are multiple contusions over the trunk and a bony deformity of the right cuff. The cervical spine is tender. Sensation to touch is absent below the mid-chest. Abdominal ultrasonography for trauma first shows no free fluid in the pelvis. X-ray of the cervical spine show subluxation of C7 on T1. X-ray chest and pelvis show no abnormality. X-ray of the right lower extremity comminuted fracture of the tibia fibula. CT scan of the abdomen shows small contained hematoma. After infusion 2-liter crystallite, blood pressure does not improve. Which of the following is the most likely cause of this patient hypertension?
Ready?
Yes.
The spinal cord injury. A neurogenic shock may occur following traumatic brain or spinal cord injury um, due to disruption of autonomic fibers originating in the vasomotor center within the medulla oblongata. A vasomotor center receives input from baroreceptors in aortic and carotid sinuses and regulates blood pressure via sympathetic fiber that descend through the lateral aspect of the spinal cord before entering the lateral horn and spinal sympathetic chain ganglia. Also, sympathetic innervation results in vasodilation and loss of vascular tone. Disruption of sympathetic fiber descending from the cardiovascular center in the medulla can also lead to bradycardia. Peripheral fluid Resuscitation is essential for maintaining perfusion. Atropine may be trial for the management of bradycardia following acute traumatic spinal cord injury. Invasive infusions such as norepinephrine may be necessary to maintain perfusion. Competing diagnoses such as blood loss in the setting of crime must be excluded or managed if present. It is not hepatic injury can lead to significant hemorrhage and shock, but will produce free abdominal and pelvic fluid on fast. Okay, next. Hello,
Oh,
Omar.
sorry. Yes, you can't hear me. I was reading the question.
Oh, you were. I couldn't hear you. I was like,
Okay,
wait,
sorry.
what happened?
Okay,
It's okay.
an 18-year-old
Right.
woman comes to the emergency department because of 3-week history of headache. The headache has worsened today and is now accompanied by mildly blurred vision. Her mother has a history of migraine. The patient is 163 centimeter tall, weight is 91 kg, BMI 34 kg per meter square. Her temperature is 37.3, pulse is 76 per minute, respiration 16 per minute, blood pressure 140 over 80. Fundoscopy examination shows bilateral papilledema. The remainder of the examination shows no abnormality. CT scan of the head without contrast shows no abnormality. Which of the following is most which of the following is most appropriate next step in the management?
Ready?
1 minute. Is it IIH?
That's what I think. I'm not. I
Okay,
mean,
okay. Let's see.
lumbar puncture. Idiopathic intracranial hypertension caused by inadequate absorption of CSF and is characterized by signs of increased ICP, like headache, papilledema, increased opening pressure on lumbar puncture without gross abnormalities on neuroimaging. It is primarily seen in young women, obese, prolonged intracranial pressure may cause headache, chronic headache, and optic nerve damage leading to permanent vision loss. Headache that are secondary to increased intracranial pressure often worsen when lying down and relieved by standing. Most common risk factors for development in IIH include female and obesity. Medication and medications associated with IIH is tetracycline, danazol, growth hormone. CT scan is important initial step in evaluation of patients with papilledema and suspected IIH to exclude the presence of intracranial mass. If the CT scan is normal, lumbar puncture is the most appropriate next step to confirm the presence of increased intracranial pressure. Management of IIH includes weight reduction, carbonic hydrase inhibitors, therapeutic lumbar puncture in rare cases, surgical intervention with CSF shunting or optic nerve sheath fenestration. Wait, let me read that one. Optical coherence tomography allows for objective measurement of optic nerve swelling. It is useful for establishing the presence of papilledema when the clinical examination is equivocal, or for monitoring the resolution of papilledema during treatment. It is not useful for establishing the diagnosis. Optical coherence tomography. And B, sorry. Visual evoked potentials involve the placement of electrodes in the scalp to measure electrical response to visual cortex. Electrical response of the visual cortex responds to standardized visual stimuli, typically an alternating black and white checkboard pattern or a series of single bright light flashes. VIPs are useful for the assessment of patients with optic nerve conduction delay, such as in the setting of MS or evaluation of ocular albinism or suspected non-organic vision loss. Okay, next.
Yes. Okay. Tell me your diagnosis.
I cannot tell from this. I
Okay.
mean, I would
Let's
say basal cell, but it doesn't
main.
have no telangiectasia, no nothing. I don't
It
think.
has nothing actually.
Yes,
Okay.
no.
Okay. Let's see. Maybe it is laryngitis. Okay. A 76-year-old man comes to the physician because of a lesion on his nose that has been gradually increasing in size for the past 5 years. He had hypercholesterolemia treated with atorvastatin. Examination shows no lymphadenopathy. There is 1 centimeter lesion of the nose. A photograph is shown. Which of the following is the most likely diagnosis?
It didn't help in anything.
It is
Ah,
increasing, isn't it?
okay, so you think it's basal cell
It,
because it's
it is cancer, some sort of cancer.
okay.
What do you think? Are you thinking it is not? It does not look like hemangioma.
Oh, it doesn't. I know for sure it's not melanoma, and I know for
Squamous
sure,
cell carcinoma. Yes,
and I don't think it's because squamous cell is below the lip, so I don't think it's squamous cell. But I don't know about the other two, so I'm just gonna guess basal cell. But I'm guessing. I'm not really sure.
we are right.
Ready?
Yes.
Oh, yeah. Basal cell, in most common form of skin cancer derived from basal cell of the dermis. Primary risk factor, UV light exposure, age, fair skin, family history. The BCC presents as pink, pearly papules or nodules with raw border and central ulceration, commonly on the sun-exposed area of head and neck. Subtypes of BCC that are less invasive are superficial or nodular. Those that are most invasive are infiltrative or formal. In all subtypes, the risk of metastasis is low, though the tumors can invade locally and cause significant tissue damage. Biopsy may be performed with a variety of techniques, excisional, shave, punch biopsy. BCC treatment requires complete surgical removal, either via excision or Mohs surgery. It's not hemangioma presents as a firm, raised, highly vascular lesion. The hemangioma typically presents in childhood and are rare in elderly patients. Actinic keratosis, a malignant lesion that may progress to squamous cell. Clinically, lesions typically appear as light pink, ill-defined macules with a gritty texture in areas of prolonged sun exposure, such as face, ear, and dorsal of the hands. Presence of central ulceration in these patients lesion is more suggestive of BCC. There is no central ulceration, but okay. Let me see actinic keratosis. What does it look like?
Okay. Next.
Mhm.
Next one is for you. Look at the picture and tell your diagnosis.
Oh, it's a picture again. Okay. Oh, yeah, that's definitely BCC.
And
So,
nothing to do. What should we do in here?
incision, but what? 1 centimeter, 2 centimeter. How do I know which
I have
when?
seen such type of question for the first time.
What? No, I know it's excision, but I don't know what. Okay, wait. Where is the lesion? In the
They
left.
haven't said anything about the lesion, even nothing. Look at the question. There is no size. It does not bleed and has no change. Okay, 6 months. There is no size included.
So we just do 5 millimeter. I don't know. 1 centimeter margin. Okay, let's do 1 centimeter. I'll just do one. I don't know.
Like
Ready?
excision with 1 centimeter margin.
Yeah, I don't know.
We don't. I don't think so. Sentinel basal cell carcinoma is locally invasive. They
Yeah,
do,
so it,
so it
there's
so we need to know the margin only.
Yeah. Ready?
So 1 centimeter. Okay, let's see. I
Yes.
think okay, 1 centimeter.
Mm-hmm.
Okay.
BCC Moscow. We know that. We know that. Okay, we know this one. Blah blah blah. Blah blah blah. Okay, complete surgical excision with a margin of between 5 millimeters to 1 centimeter is recommended as the first line treatment for BCC located in non critical areas that are amenable to complete resection with adequate margin. In critical areas of the face and delicate region, most micrographic surgery may allow for complete excision with comparative sparing of normal tissues. I don't know what that means. Excision of 2 centimeters or 5 centimeters is not necessary for treatment of BCC. The risk of viral metastasis is low, and the risk of recurrence with 1 centimeter is less than 1%. Okay. More extensive margin may be employed for primary resection of more aggressive tumors such as melanoma. Okay. That
So what's
was
the take home?
for BCC, just excision with 1 centimeter or less.
1 centimeter or less. Okay, next. A 47-year-old man is brought to the emergency department by paramedics after rescue workers found him on a snow-covered mountain. At the scene, he was alert and oriented but shivering and uncontrolled to walk without assistance. He said he had become lost white cross-country skiing. On arrival, his shivering temperature On arrival, he is shivering and reports that his toes are numb. His temperature is 36 degrees Celsius, pulse 60 per minute, respiration is 16 per minute, blood pressure 120 by 65, pulse 1. Examination show pale toes bilaterally. Blisters are noted on the fourth and fifth toe bilaterally. Sensation to touch is absent over the toes bilaterally. Pedal pulses are faintly palpable in both feet. Ankle brachial index is 0.85 centimeter bilaterally. Tetanus toxoid is administered. The feet are immersed on 100.4 degree Fahrenheit water bath for 20 minutes. During immersion, his feet become painful. In addition to administration of acetaminophen, which of the following is the most appropriate next step?
Ready?
Sorry,
Ready? Sorry.
is it immediate arteriography?
I think so. I'm not sure.
Okay.
You want me to check? Okay. Is hospital admission for observation. Frostbite is frequently seen in patients who work in the cold. Mountaineers and skiers, individuals stranded outdoors and those experiencing homelessness. Frostbite causes tissue destruction via cold-induced cell death, as well as a perfusion-related inflammation and tissue ischemia. There are several ways to classify the severity of frostbite depending on the degree of cyanosis, depth, and tissue involvement. Blistering and findings of on titanium 99 imaging. Immediate management of frostbite involves removing cold or wet clothing, transferring the patient to a warm environment, rapid rewarming by immersing the affected area in warm but not hot water, analgesia, and admission to the hospital for observation and wound care. Several adjunct therapies are often employed to limit tissue damage, including thrombolysis, Initial signs and symptoms of frostbite are often unreliable, determine the extent of injury. The clinical picture evolves as occult damage becomes apparent. It's not CDE. Intravenous infusion of heparin alone has not been shown to improve outcomes in patients with frostbite. IV heparin can be used as adjunct for IV thrombolysis, but it will not be appropriate next step. And then immediate arteriography of the lower extremities will be indicated in patients with acute limb ischemia with loss of pulses. It will not be appropriate in this patient with palpable pedal pulses. And its amputation of all the toes with blisters at 24 hours post injury is not immediately indicated and depends on viability of tissue after observation, adequate treatment, and deworming in warm water. Blisters may be a sign of non-viable tissue, though may be present in otherwise warm, well-perfused tissue as a response to initial injury. Next. Next.
Yes, an 87-year-old man is transferred to the hospital from a skilled nursing care facility 6 hours after staff noticed black skin on his right leg. He has had three strokes during the past 2 years. He has hypertension, type 2 diabetes mellitus. Current medication include metoprolol, glipizide, clopidogrel. He does not smoke. He is not communicative, responds only to painful stimuli. There are severe contracture of the lower extremity. Examination of the lower extremity shows black skin over the right ankle and foot. Pulses are absent in the lower extremities distally. Extension of the hip is limited to 110-degree. Extension of the knee is limited to 70-degree. Which of the following is most appropriate next step in the management? Pulses are absent. There is black.
Hmm. Ready?
Wait.
No. Okay.
Okay.
So it's amputation, damn it. PAD, peripheral artery disease, refers to abnormally diminished flow of blood to the extremity, um, secondary to atherosclerotic path. This most commonly affects the lower extremity. Risk factor includes diabetes, smoking, increased age, hypertension, dyslipidemia, a known history of atherosclerotic disease like cerebrovascular disease or coronary identifies the likelihood of the condition being present in other locations as well. Patients with PAD typically present with intermittent claudication, which results from insufficient blood flow to the muscles during exercise. As the flow of blood becomes progressively diminished with worsening atherosclerosis, tissue perfusion may become inadequate to meet metabolic demands and can present with pain, arthritis, and potential ischemia and necrosis of the extremity. Dry gangrene is most common in patients with PAD, although wet gangrene may also occur. Revascularization surgery may allow for salvage of the limb and improve rest pain and non-healing wounds. Um, but the presence of gangrene generally requires amputation. In this case, an immobile patient with contractures will generally not suffer functional loss from amputation, making it a sustainable choice if it aligns with the goals of care. It's not arteriography with contrast. It's useful for assessment of vascular stenosis in patients with PLD and in patients with suspected acute limb ischemia. Surgical amputation is more important next step in patients with absent pulses and lower extremity gangrene. Hmm. It's not, what was that? I was confused with something else. I guess no. Surgical revascularization in whatever percutaneous balloon with stenting or arterectomy are options for revascularization in patients with PAD. The presence of gangrene is an indication for amputation as the limb is not salvageable with revascularization. Okay,
Next.
okay. Mm.
Okay, last. Where is the fracture? Fracture in the tibia, isn't it?
Where for this question,
Next question, yes.
uh, wait, is a fracture question? I didn't even read it. Um,
Yes, question 10.
yeah. How do you know it's a fracture question?
Because looks like it is, look at the tibia.
Mm-hmm.
I don't know. I am just seeing the picture. That's why I asked. I haven't read
Oh,
anything.
you're trying to. Oh, okay. You're trying to come from the picture. Okay. Um.
Is it
Okay.
tibial fracture
I
or is
guess if you, yeah, I guess if you want to call it fracture, okay, okay.
it something else? Or is it tumor?
I don't know. I have to read the question for that one.
Okay. And the medial malleolus of the tibia is something. There is problem in here. I think so. Okay. Let's see. May not be my observation. Okay. A 47-year-old woman comes to the physician because of 2-year history of a lump that was lump on the right ankle that seems to have increased in size during the past 2 months. The lump is slightly painful when she is active. She has no other symptoms. She has no history of serious illness. Take no medication. Examination of the right ankle shows 2.8 centimeter raised lesion that is firm and adherent to the bone. There are no skin changes or limb pattern, but the range of motion of the ankle is full. X-ray of the right lower extremity are shown. Which of the following is the most appropriate next step?
Ready?
Yes, should we do biopsy? Hmm,
Yes.
okay,
Malignancies of bone commonly occur in the lower extremities and present with chronic, often localized bone pain, impalpable, bony or soft tissue lump or protuberance. A minority of patients may present with fracture of the affected bone. X-rays are important step in diagnosis. This patient X-ray demonstrate medullary and cortical bone destruction of the anterior distal medial tibia malleolus with periosteal reaction, indicating possible malignancy. A biopsy annulation is the most important step and can be performed with core needle or
okay,
open biopsy technique.
okay,
Okay, we are done. I'll see you
done.
tomorrow.
Okay.